Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of adenomatoid tumor of the fallopian tube. So this is a case of a 45-year-old female patient who underwent risk-reducing surgery for BRCA-positive breast carcinoma. And what they do with the risk-reducing surgery is that they undergo bilateral salpingio-oophorectomy. And on the low power examination of one of the fallopian tubes, this is the lumen of the fallopian tube, and there was a growth that really expanded the wall of the fallopian tube. And on high power magnification, there were some tendency here at glandular formation, but in other areas where there were these slit-like spaces dissecting in between the fibers of the wall of the fallopian tube. And on further high power magnification, these are the slit-like spaces lined by somewhat hobnaling cells, and here as well with the hobnaling, and again another example. And importantly, it dissects these slit-like spaces. They dissect in between the fibers of the wall of the fallopian tube, but there was no evidence of pleomorphism or mitosis. This is another area, another high power magnification, and here there is a tendency for a glandular formation, and sometimes the growth becomes very vague that you cannot really differentiate between the original fibers, muscle fibers of the wall of the fallopian tube or the growth of the adenomatoid tumor. And the differential diagnosis here is adenomatoid tumor, but remember the patient has breast carcinoma for which she underwent the risk-reducing surgery. So breast carcinoma should always come in the differential diagnosis, metastatic carcinoma, and should be sorted out. So this is calretinin immunostain, and it is just beautiful, highlighting at the low power the intense positivity and how the tumor really infiltrates or dissects in between the muscle fibers of the fallopian tube. And remember, on high power magnification, that calretinin positivity should show both cytoplasmic and nuclear positivity in the presence of negative background. Now, calretinin, of course, is positive in mesothelial cells, and adenomatoid tumors trace back their origin into mesothelial cells. So this would be consistent with the diagnosis or supportive of the diagnosis. But what we need also always, just to ensure the proper diagnosis, is to also test or ask for one additional immunohistochemical marker, and WT1 here. Remember that it's usually positive in the native epithelial lining of the fallopian tubes, and here it becomes extremely difficult, perhaps on this low power magnification, to differentiate the tumor from the wall of the fallopian tube. However, on high power magnification, these are the same slit-like spaces or glandular spaces that I just showed you, and this is another focus with the slit-like spaces with the hobnaling of the cells dissecting into the WT1 negative pre-existing fibers of the fallopian tube. Now, PAX8 is completely negative. This is positivity of the epithelium of the fallopian tube, while this is the tumor, the adenomatoid tumor. So it's completely negative because, again, the origin of the proliferation is the mesothelial cells, and because of the history of breast carcinoma, GATA3 just shows the negative nuclear stain. So this cytoplasmic staining is non-specific staining. It's the nuclear stain that should really be taken into consideration, and this is completely negative. ruling out the possibility of metastatic carcinoma. So the final diagnosis of this very interesting case is adenomatoid tumor. Remember that adenomatoid tumor most often is incidental finding in the fallopian tube, sometimes in the uterus, where the diagnosis might be slightly more difficult if you don't think about the diagnosis. Remember that it dissects in between pre-existing muscle fibers, and that it has a mesothelial origin, so it stains like mesothelial cells with carotenoid showing cytoplasmic and nuclear staining, as well as WT1, and other markers can also be positive. In cases like this one, where breast carcinoma is the indication to undergo the salpingo-oophorectomy, you have to rule out that this is not metastatic carcinoma. I hope you find this tip useful in your daily practice. Thank you.